Alright, sige. Let us start with the discussion on the interventions for clients with cardiac problems. Specifically, we'd be discussing heart failure, no? So let us remember and review or recall the main function of the cardiovascular system, specifically the heart. Can you remember the main function of the heart? And that is, remember, it is the pumping out of blood out of it. So meaning basically when we say there's a presence of heart failure, there's a problem with the main function of the heart, and that is to eject blood out of it. Okay? And when we say there's presence of pump failure, there is presence of insufficient perfusion. It means that nutrients, oxygen are not reaching out the major organs such as the kidney, maybe the liver, and the brain. So when we do say heart failure, there are two types of heart failure. This would be your right-sided heart failure and the left-sided heart failure. Okay, let's talk about them through. When we say left-sided heart failure, the usual problem is poor cardiac output, which lead to decrease in the perfusion of different parts of the body. Okay, specifically with the left side heart failure, the manifestations are usually present on the lungs. Okay, there would be lung manifestation. So there could be presence of pulmonary congestion. Okay, and the possible causes of this would be hypertension and coronary, or at times valvular diseases. Later on, we'll be focusing also on the discussions on the coronary artery and valvular diseases. When we talk about right side heart failure naman, usually the problem is with the right ventricle and unable to empty completely. Remember that in every ejection of the heart of blood, all of the blood from the specific chamber should be emptied out going to the next chamber. However, in this case, some of the blood are still remaining onto the right ventricle. Okay, if you can recall, saan ba nagpupunta yung blood na nasa loob ng right ventricles? Diba? From the right ventricles, it will now be ejected to the aorta, no? And ready for distribution to different parts of the body. So, patient may have an increase in volume of the blood and increase in pressure in systemic veins, and therefore systemic venous congestion can happen. So, develops peripheral edema, and the usual causes of right-sided heart failure would be right ventricular failure, right ventricular myocardial infarction, or at times pulmonary hypertension. So if you can remember the Phillips classification based on the discussion on the review of anatomy and physiology, if you were able to recall sa anatomy ninyo, or at least have read from the functional classification yung Phillips natin, no? So Phillips classification is classified into four. Kumbaga yung heart disease is classified into four classifications: class 1, class 2, class 3, and class 4. Yung class 1, by the way, all of those classes involves cardiovascular disease, no? Kapag class 1, it is known that the patient is having cardiovascular problem. However, there would be no limitation in terms of the functional ability. Ibig sabihin, yung pasyente can still perform all of the activities of daily living without difficulty. Meaning, there would be no difficulty of breathing, there's no fatigue, no? Or shortness of breath. Yung second class naman would be, there would be presence of heart disease. However, there is a light limitation. Okay? But when the patient goes to rest, nawawala or nare-relieve yung difficulty. Okay? Then the class 3 is that the patient would be having cardiovascular problem but with moderate limitations. Again, same with class 2. When a patient rests, na re-relieve yung symptoms of difficulty. Okay? But when a patient is classified into class 4, it is when a patient with cardiovascular disease is expected to have symptoms or difficulty like difficulty of breathing, congestion, fatigue, even during at rest. Okay? Kahit walang ginagawa yung patient, still meron siyang difficulty. Okay? So usually those patients are categorized or classified to have cardiac transplant. Okay? The other disease staging that we can use for classification of heart failure would be this one. So, stages 1 or stage A, B, C, and D. Okay? Kanina, dun sa Phillips classification, we're talking about the functional ability of the patient. Meaning, their ability to perform task without difficulty. In terms of this disease staging, we're talking about the structural disorder and the presence of symptoms like stage A, if high risk for heart failure without structural changes. Stage B, there's presence of structural changes, however, no presence of symptoms. So stage C is when a current or past history of heart failure with structural disorder, and stage D, wherein it is already at the end stage of the disease and requires also heart transplantation. So if you can remember your concepts on the physiology of the heart, and may include also regulation of blood pressure or just the BP itself, no, there would be the following compensatory mechanisms. So first would be your SNS or the sympathetic nervous system stimulation, the RAAS or the renin, angiotensin, and aldosterone system, neurohormonal responses, and your myocardial hypertrophy. So let's go through them one by one. So with regard to the SNS or the sympathetic nervous system stimulation, there would be, remember that the function of this is to regulate the heart rate, no, and as well as the blood pressure. So when it is stimulated, the sympathetic response, remember that there would be increase in this heart rate and blood pressure. Wherein on the other hand, the parasympathetic naman decreases the heart rate and the blood pressure. Okay? So when we talk about the increase in the heart rate, we're talking about the beta adrenergic effect. And when we talk about the BP, it is the alpha adrenergic effect. So what do you think can happen to the cardiac output when the heart rate of the patient increases? Take note that the cardiac output is controlled by your stroke volume, or is a product of the stroke volume and your heart rate. So therefore, remember that the normal heart rate is 60 to 100 beats per minute. And the stroke volume is constant to 60 or 70 ml per ejection or per contraction. So when we do multiply that, okay, that is the total cardiac output. And when the heart rate increases, imagine the heart rate is 110. Then you multiply it to the stroke volume of 70. So it will also increase. So therefore, an increase in the heart rate means an increase in the cardiac output. When the cardiac output increases, meaning that the volume of the blood that is ejected outside of the heart increases, the cardiac workload also increases. So it means that the diastolic time or the refilling time of each chamber of the heart also decreases, which may lead to increase in the cardiac output. An increase in the heart rate also increases the oxygen demand of the body. So meaning other parts of the body would be needing more oxygen. Okay, specifically the heart. So the stroke volume is improved. When it is improved, there is increase in the venous return, and heart rate dilatation would be would be stronger. Remember, if you were able to read on the Starling's law, 'di ba? From the review of your concepts in the myocardial activity, when sabi dun sa Starling's law, when the the myocardial stretch is higher, when there would be increase in the volume inside the chamber of the hearts. So therefore, when the stretch of the muscle is increased, the ejection would be also forceful. Imagine a rubber band, no? So when the more you stretch the rubber band, the more it will contract, or the more it will be forceful kapag bumalik dun sa kanyang regular or normal size. So arterial vasoconstriction can also happen, which increases the afterload, wherein the left ventricle requires more energy to eject the blood out of it, which therefore leads to a decrease in the stroke volume. So when we talk about cardiac activity, we may pertain also to to these following effects. Okay, the following are effects of the activity to the heart. So there is an inotropic effect, chronotropic, and the dromotropic effect. When we say inotropic, there would be increase in the force of the cardiac contraction. Okay, imagine, kumbaga, it talks about how forceful the contraction would be. Okay, so when we talk about chronotropic effect, it talks about the heart rate. When we do say an increase in the chronotropic effect, or a positive chronotropic effect, there would be an increase in the heart rate. When we say negative chronotropic effect, there would be decrease in the heart rate. Okay? And when we talk about dromotropic effect, it affects the conduction velocity through the conducting tissues of the heart. So meaning how fast the communication between cardiac cells are happening. Okay? Again, when we do say a positive dromotropic effect, there would be speeding up or increase in the conduction of this activity of the cardiac muscles. And when we do say there's a negative dromotropic effect, there would be decrease in the conduction or slow in the conduction. So, for example, drugs, no? The following drugs provide inotropic effect. Again, when we do say inotropic effect, this would be an increase in the cardiac contractility, meaning it can increase the stroke volume of the heart. It can increase the contraction, therefore it can increase the ejection. Okay, so this would be your dopamine, the butamine, your catecholamines like epinephrine and norepinephrine. Your digoxin also has a positive inotropic effect. Your phosphodiesterase inhibitor or milrinone, glucagon, which is used to treat hypoglycemia, your insulin to treat hyperglycemia, and amiodarone, which is used to treat cardiac dysrhythmias. Okay? Or yung changes in the electrocardiograph of the patient. The following drugs naman would be examples of your negative inotropic effect. Again, when we say negative inotropic, there could be decreased in the myocardial contractility. Examples would be your beta blockers, such as your medications that ends with lol, like metoprolol, no? Next one would be calcium channel blockers. Okay, this blocks calcium receptors of the heart, therefore decreases in the blood pressure of the patient, caused also by decrease in the myocardial contractility. Okay, usually these drugs are with suffixes of dipines like amlodipine, nicardipine, nifedipine. Okay. Class 1A antiarrhythmics like quinidine and procainamide, and Class 1C antiarrhythmic such as your flecainide. Moving on to the second compensatory mechanism, and that is your RAAS. Okay, remember it is your renin, angiotensin, and aldosterone system. Renin is a hormone that is released by the kidneys. No, so when the blood flow to the kidneys usually decreases, the kidney would feel it and it will release a hormone called renin. Okay, this renin causes vasoconstriction and can stimulate the release of angiotensin. Okay, angiotensin is a hormone produced by the kidney. Okay, specifically angiotensin 2 increases the blood pressure. However, the angiotensin released by the liver is only angiotensin 1. It needs a converting enzyme called as the angiotensin converting enzyme, or ACE as we call it, as released by the lungs to convert angiotensin 1 to angiotensin 2. So when it is already converted to angiotensin 2, it can now cause also vasoconstriction, therefore increase in the blood pressure. The aldosterone can also be stimulated coming from it is a hormone actually released by the medulla, or sorry, released by the adrenal glands. No, so aldosterone is a hormone that reabsorbs sodium, which therefore, when sodium is reabsorbed and retained in the body, it can accumulate or hold back water. So remember, when water is mixed up with blood, it can increase the blood volume. Therefore, an increase in the blood volume can increase the workload of the heart, that increases the heart rate, and therefore increases the blood pressure. Okay? So those were the mechanisms that were brought by the RAAS. Next one is myocardial hypertrophy. So the heart, it's actually the final compensatory mechanism. Okay? When we say compensatory mechanism, it is the way of the heart that that it does, no, to help increase the delivery of blood to certain major organs, okay, like the kidneys. So the cardiac muscles would increase in size. So for the term hypertrophy. So because the heart thinks that when it increases its size, there would be more force or forceful contraction. Therefore, it thinks that the effectiveness of myocardial contractility can deliver more blood to major organs. So it is when the wall of the heart thickens to provide more muscle mass. However, instead of increasing the oxygen supply to different parts of the body, the oxygen supply to the heart slightly decreases. So therefore, it provides lesser compensation, no? Kumbaga mas masama pa napapasama pa yung condition. There would still be other neurohumoral responses, such as the following that worsens heart failure. First would be the immune response, wherein there would be a release in the interleukins in the body. No, so these interleukins usually aids supposedly in ventricular remodeling. No, so interleukins are actually part of the immune system, wherein it's a large group of cytokines, no, that secretes proteins and signal molecules that were usually first seen to expressed by the white blood cells. Okay, so however, this group of white blood cells blocks, no, the or promotes inflammatory responses, therefore doesn't aid the and worsen rather the heart failure. Second would be natriuretic peptide, also known as your NP. No, it is a hormone as well, a natriuretic peptide that promotes vasodilation and diuresis through sodium loss. So there would be a decrease in the cardiac output, which can later on decrease in the cerebral perfusion. Okay, so vasopressin is also a hormone, no, at it can also be a drug to be injected. So when there's presence of vasopressin, vasoconstriction and fluid retention can happen. However, when vasopressin is released or given to the patient, it does not actually relieves the symptoms of heart failure because it can lead to fluid retention. And remember, one of the problems of heart failure is fluid retention, which later on worsens the effect to the heart failure. So, an increase in the myocardial stretch, including in the blood vessels of the endothelin, releases vasoconstrictor, which later on increases the blood pressure of the patient. Okay. As of now, do you have a concern or questions? If none, I'll be all right. If none, I'll be continuing with the discussion. Sige. Let's now go to the assessment, no? And we take note that when we do assess the patient physically before doing the physical assessment, we always start with the history taking. Okay? Again, remember there would be two types of heart failure. The left side heart failure and the right-sided heart failure. And when we say left-sided from the starting from letter L, meaning there would be lung affectation. Okay, most of the symptoms are coming from the lung of the patient. And when we talk about the right side heart failure, it's mostly the symptom would be circulatory. Okay, like fluid overload, edema. Okay, so now let's go to the assessment of the history. So sabi nga natin with the left side heart failure, it's more of the lung affectation. So you might be hearing or would want to assess presence of lung difficulty. Okay? First, you ask patients if he or she can perform activities of daily living. No? Wala bang fatigue, walang hingal habang ginagawa yung, for example, sweeping the floor, walking, going to the market, to the church. No? Are there any weaknesses or fatigue? If in case there would be fatigue, kailan nangyayari yung fatigue? Pagkagising pa lang ba sa umaga? Or habang may ginagawang activity? Or later after the day? Okay? Are there any dyspnea or difficulty in breathing? Chest discomfort? Presence of palpitations? Or a skipped heartbeat? Pulmonary congestion, if there would be presence. If you're suspecting with pulmonary congestion, alam natin na congested. Pag sabi congested, there would be excess fluid in the lungs. No? Wala pa kasi tayo sa physical assessment no? But when we talk about history pa lang, you can ask the patient if there would be presence of cough. Okay? Coughing that is not related to infection, rather coughing or presence of crackles due to excess fluid in the lungs. Okay? So, if there would be cough, assess also for possible coughing more on the evening or nocturnal comparing to the earlier part of the day. Okay? And assess if it is non-productive or productive. When we say productive, we talk about the expectorate, yung phlegm na napoproduce ng patient. Okay? For pulmonary edema, assess if there would be frothy sputum, yung pagdura ng plema. We're talking about the phlegm, no? It's not the saliva. It should be the phlegm itself. Check if it is frothy or ask the patient if it is frothy. When we say frothy sputum, this is actually just like bubbling with more air in it. And check if it is, or ask if the sputum is pink tinged. No, pink tinged, just like as if there would be rupture of small capillaries in the lungs. That's why there would be presence of pink tinged sputum. Okay, because these are actually blood. So assess for or ask for history of exertional dyspnea, a difficulty of breathing when an activity is being performed. Orthopnea, you know already orthopnea, no? It's a difficulty of breathing when in a lying position. So the patient should sit up and lean forward to have a better breathing pattern. And of course, check for presence of paroxysmal nocturnal dyspnea. PND is actually difficulty of breathing at night. Usually the patient is sleeping, lying flat on bed, and suddenly would be waking up and gasping for air. No? So that's because of presence of pulmonary congestion actually. Meanwhile, on the right side heart failure, kapag right side, kanina lang yung affected, 'di ba? With the left side. Sa right side, more on circulatory, meaning all over the body yung effect. So, ask the following questions or assess. So, signs of systemic congestion. So, ano bang signs ng systemic congestion? There could be presence of edema or manas sa lower extremities. Hindi lang sa lower extremities but all over the body, no? So, check if there would be fluid retention, pressure builds up in the venous system. Check for edema sa legs, sa thighs, or even at the abdominal wall. This is one good example of assessing fluid retention, yung number 5, weight gain. Okay, that's why you have to you have to weigh your patient daily. Okay, in the morning, then later in the afternoon as well. So, an increase, you were able to read it right with the history taking. When your patient actually sustained or had an increase in the weight of 1 kilo, we do transmute that to a kilo or a liter of fluid retention. For example, your patient is 50 kilograms. Then later, after the day, nag-weigh in siya before matulog, 52.5 kilograms. So, kanina umaga, 50, you minus that to from 52. So, may iwan 2.5 kilogram. So, we expect that the 2.5 kilogram weight gain is a fluid retention. Okay? So, meaning may 2,500 ml of fluid retained. Kapag ganun ginagawa natin, we reduce the fluid intake of the patient. Okay? That's why you have to assess the weight of the patient upon waking hours. So, assess fluid, check for any pitting edema. You know already pitting edema, right? It was discussed during the assessment part. Pitting edema is a presence of edema wherein when we input our fingers or assess or look for any indention on it. Pitting edema is measured in millimeters, no, and is graded 1, 2, 3, and 4 depending on to the depth. Check or ask for history of nausea and anorexia. This can be an indication of hepatomegaly. So hepatomegaly is another manifestation of right-sided heart failure other than edema. So check for nocturia. Nocturia is frequent urination during night. Assess for nutritional history for the salt and the fluid intake. No? Because usually this patient with right side heart failure can also have fluid and electrolyte imbalances. And check for the increase in thirst, no? Because an increase in thirst may mean or indicate shifting of fluid from the intravascular compartment to the interstitial compartment, which is an indicator also of a right-sided heart failure. Okay, with regard to the physical examination, let's go with left side heart failure. O left side muna, yung may lung affectation, no? So expect natin that assessments would be more on lung affectation. So for the physical exam, you expect that there can be decrease in the tissue perfusion and pulmonary venous congestion. So this may be associated with decrease in the cardiac output, increase in the pulmonary venous pressure. That's why patient would be coughing kasi nag-increase yung pressure sa lungs, no? There would be weakness, fatigue, dizziness, confusion, breathlessness, oliguria, and death. Why do you think the following symptoms can happen? May panghihina, may panghihilo, minsan hindi maintindihan ng maayos kasi may confusion, tapos hindi masyado nakakahinga ng maayos. It is because there would be decrease in the oxygen supply. Kasi nga, apektado yung gas exchange that happens in the lungs because of the pulmonary congestion. That's why it lead to the following. With regards to the left side heart failure, since it's more of circulatory, it is more related to the heart rate of the patient and the blood pressure, other than the presence of edema. So take note of the BP and assess for possible orthostatic hypotension. When we say orthostatic hypotension, no, coming from the discussion on the physical assessment, we know that there is an increase or more than 10 millimeter mercury change in the or drop in the blood pressure when there is change in the position from the lying position to a sitting position. You check also for the PPP or the proportional pulse pressure of the patient. It is when you deduct the systolic BP and the diastolic BP and divide it to the systolic blood pressure. So example, with the blood pressure of 120/80, you deduct the diastolic from the systolic, which makes 40, divided by the systolic BP, which is 120, and that makes 33.33 or 33% proportional blood pulse pressure. So 33 is actually a normal pulse pressure. When a pulse or when a proportional pulse pressure decreases or less than 25%, the cardiac output means that it is severely compromised. Meaning when the cardiac output is severely compromised, we expect that the supply of oxygen also, perfusion, as well as nutrients to other parts of the body, specifically the major organs, are also affected. So check for the pulse of the patient. There may be pulsus alternans. It is written here pulsus alterans, no, but it is pulsus alternans, no. It's actually a changing or frequently changing pulses from bounding as a forceful pulsation and alternating with a weak or a thready pulse. Okay, so irregular heart rhythm and of course the respiratory rate of the patient may also increase more than 20 breaths per minute because the lung is compensating to the decrease in the cardiac output. Again, for the left side heart failure physical examination, check for the mental status. So there could be confusion of the patient. Palpate the precordium. So if you would be observing, there can be displacement of the apical impulse. Take note when we say displacement, there is a deviation of the normal location of the apical impulse. We note that the normal apical impulse location is at the 5th intercostal space of the left side of the chest, mid-clavicular line. Okay, always remember that the PMI is located at the left side of the chest, 5th intercostal space, mid-clavicular line. So there could be presence of S3 and S4, which are ventricular gallops or ventricular murmurs. And assess, when you auscultate, assess for presence of crackles and wheezes. Crackles and wheezes may happen because of the increased fluid retention sa ating lungs. Sa right side heart failure, since it is more on systemic congestion, check on the neck veins here. Okay? Look on to the jugular vein pressure of the patient. Usually it is more than 10 centimeter water. Measure the abdominal girth because this may be an indication of ascites or an edema in the abdominal area. Hepatomegaly, hepatojugular reflux, and ascites. As I've mentioned, ascites is abdominal edema. How do we assess hepatomegaly? Of course, upon palpation, we can feel that the liver is quite enlarged. Hepatojugular reflux is when you ask the patient to lie about semi-Fowler's, then you ask the patient's head or face to turn on the left and observe for the jugular vein. Then you try to press with your both hands the liver and assess for your congestion of fluid at the jugular vein. Okay, so that is reflux of the hepatojugular. Check also for any presence of dependent edema. Usually, dependent edema can be observed when a patient is a bit when a patient is in a specific position for a while. Then when he or she turns, so tignan nyo yung last position niya na extremity, for example, or even at the back of the patient, baka may edema na rin doon. And of course, as I have mentioned earlier, you daily weigh the patient to observe for the changes in the fluid retention or body weight. Assess also for both left and right-sided heart failure, the psychosocial. No? Usually, patients with heart failure are having anxiety. Lalo na there's presence of difficulty of breathing. No? There would be fear of death from this patient. So assess for any presence of anxiety. Why is it important? Because so that we can alleviate it or at least help the patient cope with the anxiety. For the laboratory examinations, the physician may order and we can assist on it. Sodium, potassium, magnesium, calcium, and chloride determination. Okay. We do assess also the BUN, creatinine, and creatinine clearance to check the function of the kidneys, especially these are related to fluid congestion. No? So this may help us in determining the ability of the client to eliminate excess fluid. Check for any presence of proteinuria or high specific gravity in the urinalysis. Remember that proteinuria is a presence of leakage or excess elimination of albumin. No? Why is it necessary? It's important for us to determine albuminuria or proteinuria because that albumin, we know for a fact that it holds the oncotic pressure. So meaning it prevents shifting of fluid from the intravascular space to the interstitial spaces. So therefore, a decrease in the protein or albumin levels in the blood may lead to edema. No, that's why we assess proteinuria or albuminuria in the urine. High specific gravity or specific gravity, actually, the importance of this is for us to determine fluid balance of our patient. When there's high specific gravity, it means that the patient is actually dehydrated. So it means it can be an indication of fluid shifting from the intravascular to the interstitial spaces. You assess also the hemoglobin and hematocrit because we determine that those are important in delivering oxygen supply to our major organs. Assess for arterial blood gases, for any presence of alkalosis or acidosis because both can happen, no? Respiratory acidosis coming from the carbon dioxide retention and respiratory alkalosis due to hyperventilation. Okay, and of course, metabolic acidosis due to lactic acid No, lactic acid may be produced because of anaerobic metabolism of the muscles. Usually this happens when there's presence of chest pain, no? And chest pain can happen because of poor oxygenation over the anterior chest wall. We may do also chest x-ray to assess presence of cardiomegaly, that is increasing the size of the heart. You were able to have your x-rays before, no? At one point in time, you have done x-ray and you were able to see the silhouette of the heart. Okay, so in some patients, we can determine cardiomegaly by just doing x-ray. No? But more than that, we can also assess presence of pleural effusion with your patient. Pleural effusion is a condition wherein there is accumulation of excess fluid at the pleural cavity of the patient. We know that pleural cavity contains minimal amount of fluid, that is about 5 to 15 ml, just to lubricate the lungs when it is inflating and deflating. However, pleural effusion happens when there is an increased fluid in the lungs or because of congestion of the lungs brought by heart failure. Others that we may perform, electrocardiogram, to determine any presence in dysrhythmia. Baka meron palang myocardial infarction ng patient together with heart failure due to decrease in the oxygen supply. No? Your echocardiography, also known as your 2D echo, for the functionality of the heart. We may perform radionuclic studies, pulmonary artery catheters. These two can measure the pressure at the pulmonary artery. Because remember, meron tayong pulmonary congestion, meaning there is increase in the fluid in the lungs, specifically in the pulmonary artery as it passed through. That's why we can do PAP or pulmonary artery pressure assessment and PAWP or pulmonary artery wedge pressure. Okay. The following could be the nursing diagnosis that may work on patients with heart failure. Okay, this could be impaired gas exchange related to ventilation perfusion imbalance, decreased cardiac output, and activity intolerance. So, what could be the interventions that we may implement? So, for gas exchange, ventilation assistance is very important. So we expect that patient may be having difficulty of breathing. So as part of the assessment techniques, we do auscultate the patient's breath sound every 4 hours to monitor. For example, at the first assessment, there's presence of crackles and wheezes. So later on, after 4 hours, we check if these manifestations or signs and symptoms decreased as well. So you position your patients in a high Fowler's position or up to sitting position so that lung expansion can actually occur. Repositioning may be necessary for postural drainage. Coughing and deep breathing exercises every 2 hours can help also lung expansion. For decreased cardiac output, we may implement non-surgical management such as hemodynamic regulation by administering drugs. Okay, drugs that reduce the afterload, and this could be your ACE inhibitor, which may act as vasodilator. Remember, as I mentioned during the discussion of RAAS, that angiotensin is a good, specifically angiotensin 2, is a good vasoconstrictor that increases the blood pressure of the patient. So what we would want to do is to decrease it so that it may decrease the afterload. No? So we can do that by preventing the conversion of angiotensin 1 to angiotensin 2. Remember, sabi natin kanina, there is hormone released by the lungs, which we call as angiotensin converting enzyme. So what we would want to do is to stop the release of angiotensin converting enzyme from the lungs. Therefore, we can give ACE inhibitor. Okay, from the word itself, it inhibits the release of, or it inhibits the action of the angiotensin converting enzyme. Okay, therefore leads to vasodilation. Next one would be human B-type natriuretic peptide. So it causes natriuresis and promotes now vasodilation. An example of this is nisiritide. That is a drug that is actually a natriuretic peptide. Diet therapy. We can also help patients with heart side failure. Sabi natin there is congestion, no? Meaning there's fluid retention, or in short, there's excess fluid in the body. So we can help eliminate excess fluid by reducing the sodium intake to less than 3 grams daily. Okay, but hopefully, actually the 3 grams daily is good amount of sodium dose for patients without heart failure and cardiovascular problem. So you revise this to less than 1 gram daily, no? Less than 1 gram. We don't want to fully eliminate sodium because for a fact, we know that the function of sodium is also necessary uh, for for the muscles function, no, as well as for cellular activity. Okay, that's why we do not want to eliminate fully the sodium. Since patient is also congested, we would want to restrict the fluid also to 1 liter per day. Okay, and take note to weigh the patient daily and measure accurately the input, especially the fluid input, as well as the output of the patient or the elimination. With regards to the drug therapy, no, we may administer per order diuretics, and there could be 3 types of diuretic, no, that we can administer to your patient. So this would be your loop diuretics in a form of furosemide. The downside with the loop diuretic is that it does not control because we do eliminate when we urinate, di ba? We eliminate fluid, excess fluid, and electrolytes. With regards to the loop diuretic, it cannot control what to eliminate. So it will include all the excess fluid and all the electrolyte. The downside is that we may be losing some of the electrolytes that we may actually need. For the thiazide diuretic in the form of hydrochlorothiazide, so these are usually used for older clients with mild overload that is actually self-limiting. So less diuresis, so therefore dehydration less dehydration can happen. So it helps actually in gradual onset of diuresis. That's why it's best for older adult, no, to prevent dehydration. The other type of diuretic actually is so as I have mentioned, your loop diuretic and thiazide diuretic in a form of metolazone. But another type, a new form, is your potassium sparing diuretic. As I mentioned earlier with the loop diuretic, no, it can also eliminate electrolyte that may be not necessary. So with regards to the potassium sparing diuretic, it can eliminate excess fluid except for the potassium. So it filters potassium and retains potassium inside the body. So therefore, we do not lose unwantedly the potassium that we might need. No, if in case you're giving non-potassium sparing like furosemide to your patient, you monitor for potassium deficiency. Okay, so neurologic and muscular complaints of the patient like cramps can also be monitored. In terms of the diet, we can add potassium-rich foods such as orange, banana, melon, cantaloupe to your patient. Physician may also order potassium supplements together with loop diuretics. So nitrates can also be given in a form of isosorbide or Imdur, no? These are good vasodilator. Sabi natin the problem earlier is vasoconstriction, no, that increases the blood pressure of the patient. Therefore increases also the cardiac output. So vasodilators can actually help patients since it promotes increase in the size of the lumen of the blood vessel. Therefore, it can control the cardiac output, control the blood pressure. No, it can be given in a form of intravenous drug, so IV, no, oral or topical. Take note that the IV should not be administered directly to the to the eye to the veins, no, it should be administered in, or it should be incorporated in a volumetric chamber. Okay, so me or volumetric chamber, you know it, right? Or what we call a soluset. So you mix, the usual is you mix 90 ml of D5 water, or at times we can use plain NSS plus 10 milligrams per 10 ml of your isosorbide, no, or your nitrate. So you regulate that depending on to the physician's order, usually for an hour, no. So because we would want to give 10 milligrams or about, yeah, 10 milligrams to your patient. Okay, so that is actually regulated. Oral, of course, we can give orally once per day. And for topical, these are what we call as patch. Okay, your NTG patch or nitroglycerin patch. This should be given once per 24 hours to your patient. When you do administer the patch, no, make sure not to touch the sticky part of the patch because that contains medication. When you actually touched it, some of the drugs may be absorbed by your body. So baka you may feel lightheaded, no, or at times your blood pressure can also be affected as well as your heart rate. So what we do recommend is when a patient or a nurse, rather when a nurse is administering patch of nitroglycerin to the patient, you wear gloves. Okay, so that if in case you touch accidentally the sticky part with the drug, you will not be having the effects of the vasodilator. Okay, when you apply the patch to the patient, make sure that the chest that you apply on is not hairy so that the patch can stick on, and that there's no presence of keloids on the area. So when upon administering, make sure to monitor the blood pressure since it is expected that one of the side effects is to decrease in the blood is a decrease in the blood pressure. Okay? And check also the heart rate of the patient. Ask patient to tell you if there would be presence of headache and lightheadedness because those were expected side effects. Another drug that we can administer is your digitalis, okay, or digoxin. It's actually a drug that enhances cardiac contractility. Remember from the example earlier on inotropic drug that can increase cardiac contraction. Okay, this is one form, your digitalis. So digoxin decrease myocardial contractility, so meaning it can decrease or reduce as well the heart rate of the patient. It slows down the conduction, meaning if we describe it using the dromotropic effect, there is negative dromotropic effect. So digoxin has positive inotropic effect, negative dromotropic effect. Okay? It inhibits sympathetic activity and enhances parasympathetic activity. That's why we expect that the heart rate of the patient can decrease. So take note as a nursing consideration, we do not administer digitalis when the patient's heart rate is bradycardia or bradycardic. Okay, so take note, check the BP, check the heart rate, prior to administration of digitalis. So it also produces mild diuretic effect. So it's expected that your patient may ask to urinate few minutes after administration. So it increases automaticity with hypokalemia, which may produce ectopic beats. So patients may have a little skip beats, no, or heart beats. Digitalis, in case, may lead to toxication or hypertoxicity. Okay, because of maybe an increase in the dosage. Nakalimutan ng patient, nakainom na siya, nadoble niya yung dose for the day. Okay? So, we can administer antidote, no, in a form of digibind. Okay? DG as in D-I-G-I, bind, B-I-N-D. So, digibind is the antidote just in case for digitalis toxicity. So digitalis is absorbed from the gastrointestinal tract. So we do not or prevent a patient from taking antacid together with this one because it may interfere the absorption. So for the toxicity, as I have mentioned, you should be monitoring from your patient presence of anorexia, fatigue, and changes in the mental status. Premature ventricular complexes are common with the patient. That's why I have mentioned earlier, no, with regards to the skip beats, no, like this one, the ectopic heartbeats. So because partly expected are premature ventricular complexes from your patient. So monitor also the apical impulse and the heart rhythm of the patient as you are administering digitalis. Okay? Other questions or other concerns as of now? If none, I'll be continuing with other inotropic drugs. Okay? So others, if you do have questions, you just type in the chat box or the comment section. Then beta-adrenergic antagonist or agonist rather. Example would be your milrinone, okay? Or milrinone, which is phosphodiesterase inhibitor, which enhances the entry of calcium to the heart or to the receptor of the cardiac muscles, no? Then beta-adrenergic blockers, which decreases the levels of sympathetic stimulation. And of course, the catecholamine. No? Remember that your catecholamines are epinephrine and norepinephrine. So instruct clients to weigh daily, report any signs of worsening heart failure. So how do we determine if there's worsening heart failure? O worsening nga, sabi, lumalala. Okay? And if you'll be recalling earlier on that heart failure, usually expect that there could be difficulty of breathing, no? Problems with the weight or increasing the weight. So changes in the weight of the patient actually is a good indication of worsening heart failure. Instruct client to weigh daily and report any signs. Titrate drug upward and evaluate client weekly as necessary. So quite slow or a modest drop in the blood pressure is acceptable. All right. So now we're done with the medical management. Let's go to the surgical management for heart failure. So we do have 3 here. Your heart transplantation, ventricular assist devices, and some of the newer surgical therapies. So with the heart first with the heart transplantation, no, it's easy to understand, no. Just changing of the heart transplant. No, we know for a fact that transplant is necessary when the the malfunctioning organ has to be replaced. Okay, for this instance, the heart. So ultimate choice for the surgery or or heart transplantation is the ultimate choice of surgery. Ventricular assistive devices for clients are usually done for patients with or usually given or performed to patients with who are actually awaiting for heart transplantation. Newer surgical therapies such as your PLV or partial left ventriculectomy, heart reduction surgery, endoventricular circular patch cardioplasty, acorn cardiac support device, and the myosplint. So PLV is just basically also known as heart reduction. No? From the word itself, partial left ventriculectomy. It means that we reduce the ventricles of the patient by resizing. Okay, so we remove a part of the ventricles so as to decrease the size, no? Because one of the problem is cardiomegaly, specifically the left ventricle. So for the circular patch, from the word itself, patch, no, it provides support to the heart. So we put in a patch attached to the heart. So it actually provides support as it contracts. So same din yung purpose with Acorn cardiac support device, no. It acts as support. Acorn is actually looks like, do you know the wrapper of the or the pouch of the apple, yung parang net, no? That is how an acorn looks like. So we put the heart or we put that acorn around the heart for support as it contracts. And of course, myosplinting as well. Yan. So for the energy management, when we say energy management, we would want the patient to actually um, regulate the activities that he has for the day, no? Kumbaga, scheduling of activities may be necessary to decrease the cardiac output, but more so to decrease the workload of the heart and to decrease oxygen demand. Kasi pag mas active ang patient with cardiac problem, mas mataas ang oxygen demand, no? Whereas kapag hindi masyadong kumikilos, hindi masyadong gumagalaw, mas mababa ang oxygen demand. So, physical and emotional rest may be necessary. So, day 1 post-surgery, we can ask the patient to sit up in a chair just to do regular meals, no? And leg exercises can be done para are also still working. 2 days or day 2 after surgery, ambulation with physical therapy may be needed. Then check BP, pulse, and oxygen saturation before and after the activity. Di ba ta-type mo yung pangalan natin pareho? Eh di pakita mo na lang ako. Pero na-type mo na yung name natin. You should check the blood pressure again, pulse, and oxygen saturation before any activity that is performed by your patient. So assess, no, sabi natin kanina, monitor the patient frequently, every 1 to 4 hours. Kung post surgery then we assess patients and monitor for pulmonary edema. Rapid acting diuretics, Lasix, IV can be given over 1 to 2 minutes to avoid ototoxicity. since ototoxicity is one of the complications of administering Lasix. Oxygen support may be necessary. So it's good also to put patient or place patient in a high Fowler's position. IV morphine sulfate and nitroglycerin can be administered. As I've mentioned earlier, no, we give the nitroglycerin or NTG in a slow infusion dun sa ating volumetric chamber, or best kung merong infusion or syringe pump. We may also insert a Foley catheter per physician's order for us to monitor accurately the urinary output of the patient. So following would be the health teachings that we can provide. Activity schedule, monitoring of indication of heart failure, drug therapy, diet therapy, and advanced directive. With regards to the activity schedule, as I've mentioned, we have to schedule the activity on a day-to-day basis or for the whole day, 24 hours, just for us to provide support to the patient so that he may not be easily fatigued over the day. No? So, but we would want to still promote physical activity. Okay, so we want to allow patient to stay active as possible. However, a development of a regular exercise program is a good idea. So persistent crackles and uncontrolled edema may be an indication that the patient is unstable and cannot perform exercises. We may know that a patient is good to go when he can be able to perform 200 to 400 feet of walking daily. And chest pain or dyspnea. So if there would be chest pain or difficulty of breathing during an activity or physical activity, patient can slow down, like during exercise. Pwedeng magpahinga or pwedeng uh, dahan-dahanin. Okay, yung activity. If in case the patient may ask for sexual intercourse, sexual activity, they may also engage in sexual activity as long as they do assess their capacity. No, usually a good indicator is when a patient is able to walk about 200 to 400 feet per day. Okay, that may be a good indication that the patient can actually perform. So the following would be indications of worsening heart failure. Titingnan natin kung lumalala ang pasyente, no? By observing the weight gain. A rapid weight gain is an indication of a worsening heart failure. That's why it's a must for us to weigh the patient daily at least. So increase in exercise tolerance lasting 2 to 3 days. Cold symptoms more than 3 to 5 days. Exercise awakening at night to urinate or excessive rather, no? Meaning patient is having nocturia, no? Ihi ng ihi sa gabi. Kasi ayun pala increase ang fluid retention. So check also if there would be dyspnea or angina at rest. Kahit nakapahinga, may difficulty. And an increased swelling in the feet, ankles, or the hands. At times, even at the back, sa likod ng patient when he or she is lying flat on bed. For the drug therapy, the following drugs has been mentioned earlier, no? But what we would want to emphasize is that we teach the patient on what to do specifically with these drugs. For digoxin, since we cannot give if the heart rate of patient is less than 60 or when bradycardic, we teach the patient how to count the pulse rate. Okay? Thus, we teach them also when to take it. No? Take diuretics. Ayan, diuretics naman. When we teach the patient, we instruct them to take it during the morning. Because for the reason it promotes urination, right? So we don't want the patient to urinate mostly at night para yung sleep nila is still full. No? Then, weigh the patient each morning. Emphasize the relationship between weight gain, fluid retention, and heart failure. For the ACE inhibitor, you move patients slowly when changing position, since hypotension one one of the side effects of ACE inhibitor. Okay, hypotension. That's why you ask the patient to change position slowly. You educate also the patient that possibly, since one of the side effect, there could be dry cough, no coughing of patient in case with ACE inhibitor. So patients with diuretic and ACE monitor serum potassium and renal function. So we may administer potassium supplement and or can be given with potassium sparing diuretics or spironolactone or aldactone. If in case with regards to the diet, you can give additional potassium rich food to the patient. Ayan, as I mentioned, restrict dietary sodium to less than 1 gram per day and may use lemon, garlic, and other herbs to enhance the flavor rather than putting more salt. Okay? You can enhance the flavor by adding up other spices. Um, ito, no, advanced directive, it is not much talked about in the Philippines, but at least we do offer advanced directives to your patients. Okay? If in case clients wishes in the event of cardiac arrest, kung gusto pa niyang magpa-perform ng CPR or maybe he would want to have a do not resuscitate order. Okay? When we do say do not resuscitate, there would be no resuscitative or reviving procedures that can be done to him or her, just in case that he wished to. No? And of course, CPR, kung gusto pa or hindi, magpa-cardiopulmonary resuscitation. Okay? And that ends the discussion for patients with heart failure. So, thank you very much.